still on a vent, but she's awake. She can follow, she can track, and she can answer yes or no questions by nodding her head. But her blood sugars have been laid down. Linda is on the road to recovery. We can facilitate this by early mobility and RN MD rounding. And the team leading is Dr. Conrad and Joan Romero from Intensive Care Unit.
Good afternoon, everyone. I just tried to knock off my partner here.
You're a doctor, that's okay.
Okay, so we're just moving right along. Linda arrives in ICU. She's initially intubated and on a propofol infusion. But we have been instituting a culture of minimal sedation in our ICU for the last couple of years. So the propofol gets immediately stopped. And within a few minutes, Linda wakes up. I mean, Linda is a 37-year-old. She's got some medical problems, but she was working. She was a functional individual prior to this. So Linda wakes up, and she, along with her family, is able to witness the care provided by our ICU multidisciplinary team. So this is our team photo, very recent, last week, and this was taken to celebrate the Everyday Heroes Award that we received for the ICU mobilization program. So here it's the physicians, the nurses, social worker, there's our physical therapist, so a good representation here. Multidisciplinary collaboration is an interaction among healthcare professionals from different disciplines, therefore enabling the knowledge and skills of all these different professionals to synergistically influence the care being provided to the patient. So in the end, the sum should be greater than the different individual contributions. The goals and the effects are not only to improve care and satisfaction, patient satisfaction, but also, frankly, to enhance workplace enjoyment and job satisfaction, which are also very important. Studies show that workplace enjoyment is more important than money as far as staff retention and staff performance. So getting along and feeling comfortable at work is also very important. Our team roster includes physicians, mostly the intensivists, but also surgeons and physicians from other disciplines, nurses, respiratory therapists, pharmacists, dietitians, physical therapists, social workers, and last but not least, our secretary is very important. The most basic and the most important of our multidisciplinary activities is our daily bedside rounds. This photo was taken with the patient and the family's permission. And you see our team here, rounding at the bedside, myself, along with the primary nurse, the charge nurse, respiratory therapist, and pharmacist. We're all staring at the computer, I guess, as it always happens. I guess we are looking at the labs or looking at the x-rays. I guarantee that we also look at the patient. And you can see here that the patient seems to be happy about that. He's giving us the thumbs up. This is a work in progress. We have been doing this for a while, but definitely can still be improved. Well, our next project is going to be to try to develop a more structured approach to bedside round, having more of a more structured format that people can use, so things are going to be more consistent, and also we can increase accuracy and efficiency. Now, our best known, I guess, effort so far, and one of the most successful, has been the ICU mobilization program, and I guess I'm going to turn it over to Joanne.
Thank you, Chiara. So we believe that we can impact care in our ICU by doing early mobilization. And so Linda, 37 years old, what our goal is for her when we did our multidisciplinary rounds is to get her out of bed on a vent, actually after 2 to 3 days. Since what our goal is for her is not only the short term, we're worried about short-term outcomes, but we are also wanting to focus on the long-term outcomes. According to the IHI and the studies that they did, if we mobilize our patients early on in the ICU, we can impact long-term outcomes, which is number one, Linda can go back to work. Number 2, she will be happy and not depressed. And number 3, she can walk out of here and go to the malls or whatever she did before. So after the rounds that we do, we assess her prior level of functioning, and we've determined that Linda has work. And current level of functioning, we will assess. Of course, the propofol is already stopped. We use less sedation in our ICU so that they can follow commands and do passive and active range of motion exercises. So let's say, for instance, this patient right here, our very first patient, he's an example of a person who's determined to get out of bed and actually pull out that ED tube. When we saw him the first day of surgery, he had a lap chole, a very big abdominal surgery with chest tubes, and first day post-op. He was struggling. He looked miserable in bed. And when I saw him, and that's when Kiara and I went to IHI, and they said, you should not have any exclusion criteria. Just get them out of bed. And this is what we did with him. But now we're using a protocol, and we're following that. And we know for a fact that more and more, we've been doing early mobilization for 1.5 years now, and our goal is to get them upstairs, which is the step-down unit. So from bed to upstairs, that's the philosophy that we have in our ICU. So these are only a few of our patients that we have gotten out of bed, although, at first they looked miserable, but after that, they got extubated the same day or the following day. And it's true for right now because even the family members will go, are you not going to get our relative out of bed? They asked for it already. So this is something that we do every day.
Thank you. And moving right along, I mentioned the daily bedside rounds. This is probably going to be one of our main projects for the next year, how to enhance daily bedside rounds involving more